Hello, everybody. Thank you for inviting me today, and thank you for that great introduction. I appreciate the time today, and I hope to be able today to talk to you about how genomics can help your patient. So just first off, I have no conflicts of interest to disclose. So the objectives for today's talk, and what I hope that you will take away from this, is that you'll be able to recognize when to refer your patients to genetics, to understand the value of a genetics assessment for your patient, for their family, as well as for you, and to become familiar with the tools and trends, or at least be introduced to the tools and trends in genomics that will impact your practice in the coming years. So to start off, I'd like to introduce you to Olivia. So Olivia is a patient who has just joined potentially into your practice. She's a 6-year-old girl and has just started grade 1 in September. As you're sitting down for your consult for the first time when you meet Olivia, the mother mentions casually that she had a heart problem at birth and was fixed right after she was born, but she's doing well and is healthy with no other concerns. When you ask about how school's going, you learn that Olivia's teacher feels that she is a bit behind at school and is concerned about some mild delays. So in follow-up, when you do your developmental assessment, you do indeed confirm that there is some concern about some mild developmental delay in Olivia. Olivia also mentions to you that she notices that she's shorter than everyone in her class. And so in your measurements, you confirm that in fact, she does have short stature. So what I want to point out here are really the red flags, and hope that you would learn to recognize these red flags in your practice. When you reflect upon Olivia, you notice that she has a congenital heart defect, there is some level or query developmental delay, and short stature. So when you think about these are 3 different systems that are impacted in Olivia, this may conclude, or this may lead you to the conclusion that there is a possible genetic syndrome in Olivia. As you know, a syndrome is a recognizable set of symptoms and physical findings, which may indicate a specific condition for which a direct cause is not actually always understood. So now that you've recognized these red flags and understand that there is a possibility of an underlying genetic disorder here, what are the next steps? So first of all, one of the key things is knowing when to refer to genetics. The questions you might want to ask yourself are you comfortable with ordering a genetic test, as well as consenting your patient for the test? Do you feel confident that you can have that conversation with your patient and her family? Do you have any genetics expertise or training that can help inform this conversation? And what is your level of genetic or genomic literacy? I think it's important at this time to assess this, because traditionally genetic testing has really occurred in the specialty clinic setting or in the genetic setting. With advancements in genetic technology and genomics, we know that a lot of genetic testing and conversations around genetics will start to happen more and more at the primary care level. And so we need to start thinking about, as you know, in the primary care setting, how can we set ourselves up to handle this level of inquiry and this new level of burden around genetic testing that will be landing more in the primary care setting. After identifying again the red flags and thinking through your comfortableness with genetics, given her symptoms weren't something that you were overly familiar with, you did send Olivia to genetics for assessment. So coming back to Olivia, and the testing gets sent and the referral happens, it comes back to you with a genetic report comes back to you showing a pathogenic, meaning a damaging variant in one copy of her PTPN11 gene. And this is a gene that is very well known to be associated with a syndrome called Noonan syndrome. And this is a genetic syndrome that can be associated with congenital heart defects, hypertrophic cardiomyopathy, and multiple other health concerns. Often, this is the result of a sporadic genetic variant, but in some instances can be inherited from a parent in an autosomal dominant fashion, meaning that you only need one copy of this genetic change in order to be affected. The clinical presentation can vary significantly and even between family members. So it's not uncommon that we find that, in fact, what we thought was a healthy parent actually has the same genetic condition. We learned that Olivia has a 50% chance of passing on the genetic variant to any future children. And we also know that if one of her parents is found to also have this genetic change, that there would be a 50% chance that that parent passed that variant onto one of Olivia's siblings. And we now know that Olivia's family members, starting with their parents, can be tested for the variant. So, why is all of this information important? And why is it important for her, as well as why is it important for you as her care provider? We know that having this diagnosis enables early screening and diagnosis for other health problems, other types of heart concerns, hearing loss, genital urinary issues, skeletal issues, neurological concerns, and dermatological issues. We know that testing and critical screening for family members can now be initiated. And often in a family practice, this is something, we practice family-centered care. So knowing about these risks and potentially these risks in other family members can also be helpful for you in your practice. We know that future pregnancy management will be available to not only to Olivia, but potentially to her parents, especially if one of them is positive, as well as screening, such as being able to do a fetal echo now knowing that there may be an increased risk for another sibling or a future sibling to be affected. Pre-implantation genetic diagnosis, or PGD, is also available for the parent should they be a carrier of this genetic variant. Which enables them to make informed choices about their next pregnancy and being able to test an embryo ahead of time before implantation in order to not have another pregnancy with this type of genetic variant. So it really allows for options and to even allow to have conversations around those options. And the primary care provider, as well as other members of the care team, now have an improved understanding of Olivia's needs and how to best support her and her family. Another case I want to review with you is the case of Martin. So Martin is a 30-year-old man who starts his care as well in your practice. As he is speaking with you, you learn that he is healthy, he has a good job, and runs 3 times a week. So he's fairly active. He mentions to you that he sometimes feels short of breath and fatigued. He also mentions that his father passed away in his 40s, suddenly, of a heart condition, which is why he exercises so regularly. Again, what are the red flags that you see here? So, knowing that he has a father who passed away at a very young age, suddenly from a cardiac event, is certainly a red flag. Because of this knowledge, you investigate further the family history and find out that, in fact, it's not just his father with the alarming history, but he also has a brother who has an abnormal heart rhythm that he believes his brother is taking medication for, but doesn't know the details. And turns out that his cousins and aunt and paternal grandfather also have similar types of heart conditions, none of which are well described or really understood by Martin. So significant family history. Looking at this family tree or pedigree, you can see that the shaded individuals indicate people who are affected or potentially affected by a heart condition. And this is very suggestive of an autosomally dominant inherited disorder. You also recognize that Martin could potentially be showing symptoms of a possible cardiac disorder. So all of this leads you to the conclusion that he may actually have a type of inherited cardiac disease. So what next? Again, thinking about genetics. Because this is complex, involving both the heart and potentially a significant family history, you would want to think about referring him to a specialty clinic, a cardiac genetics specialty clinic. If there is one nearby, we're fortunate in Toronto that we have many options. However, if this is not the case, first and foremost, you would want to refer to the cardiologist for assessment of symptoms and think about referring to a genetics clinic for assessment of the family history, as well as thinking about molecular genetic testing options. You follow through with the referral to the cardiac genetic clinic, and they perform not only an echocardiogram, which ended up diagnosing Martin with hypertrophic cardiomyopathy. They also organized a genetic test for cardiomyopathy disorders that covered looking at 60 of Martin's genes at one time. All these genes are known to be associated with different types of cardiomyopathies. It was determined that Martin had a pathogenic and a damaging variant in one copy of his MYH7 gene, which was responsible for causing his HCM. HCM is one of the most common inherited cardiac disorders, affecting 1 in 500 people, that really often goes undiagnosed until a severe event or sudden cardiac arrest. We also know that HCM can present at any age, even at birth, and that the symptoms and severity can vary greatly between people and even members of the same family. So this is a critically important diagnosis for you to have made, or for the genetics team to have made, and they've sent you back a report. So why is this important, and what does this mean for you and for Martin? So this result changes Martin's current and future clinical management. He can now have proactive screening and prevention of an adverse cardiac event or a heart failure. He can be given appropriate medication therapy and can even have the option of having an implantable cardiac device. Sometimes the management is guided by the specific genetic change or even the specific gene. Also, this would allow him and others down the road, or potentially future children of Martin's, to benefit from discoveries of targeted therapies that might prevent HCM. Again, knowing the underlying genetic cause allows for the possibility to develop targeted therapies. This allows Martin to make informed choices about family planning and enables him and his family members to have proactive screening and to take preventative measures. This enables his family members to even be to determine if they are at risk. So, for example, again, because we have identified the specific genetic variant in Martin, his family members can be tested for that variant and know whether, in fact, they are at risk. And if they are, to be engaged in proactive screening. And again, for you, this allows the provider to be proactive and manage their patients in a preventative way rather than a reactive way. This last point, I think, leads me to my final slide, which is that now the focus of genomics and genetic tools is really around being preventative and proactive in the way that we treat and care for our patients. There are many new tools and trends in genomics, and they will be coming your way if they're not already knocking on your door. One example is clinical whole genome sequencing. Right now, most of the whole genome sequencing that's done here is done on a research basis. But very soon in Canada, or in Ontario, I should say, this is a test that will be available clinically. And in the long term, this is likely something that will be incorporated into newborn screening programs. Whole genome sequencing allows us to look at the entire genetic makeup of a patient or of a person. And we're still learning about what the makeup is and how we interpret all of that information. But what we do know is that by looking at somebody's entire genome, instead of taking a targeted approach where we might be looking at one particular cause or for one particular disease, we know that this kind of test can open up a whole other host of concerns for that patient and identify things that that family or that patient might be at risk for down the road. So again, we can use that information in a proactive way to prevent and to do screening to prevent future diseases. Another tool that will be very soon incorporated into regular stream clinical practice is the practice of pharmacogenetics, which is looking at somebody's genetic variants and using that information to appropriately prescribe drugs based on how their genetic variants interact with the drug, or potentially don't even work with certain types of drugs. So using this type of technology, we can really use precise treatment for the family, or for the patient that you're treating. And finally, direct-to-consumer genetic testing. Likely, this is something that you have seen in your practice already. Now, there are tools that allow individuals to take genetic testing into their own hands. By spitting into a tube and sending off a kit to a laboratory, they can then get back a report looking at many, many, many different genes. And then take that report back to their family doctor to discuss and think about how they should be, managed based on these results. So the key point here is that not all direct-to-consumer testing, genetic testing companies are created equally. Some do not produce clinically validated results, and it's important, again, to build up your genomic and genetic literacy around these type of technologies and really understand when you can rely on test results and when you might need to seek validation or, again, refer out to genetics to understand really the impact of these results. So I think that my time is up. I want to thank you very much for your attention today. And I hope, again, that we've managed to highlight in this short time together some of the red flags to look out for, and highlight when you should be referring to genetics. I hope I've answered the question as to why this information is important, not only for your patient, but for you and your practice. And hopefully you've been introduced to some of the tools that, like I said, will be coming your way if they haven't already landed on your doorstep. Thank you very much again, and I appreciate your time.